So hi everybody and welcome to the Mirrors Australia webinar. I think this is our seventh webinar in this AN-ACC series. So if you've been participating in all of those webinars, thank you so much for turning up. Straight away, I'd like to begin by acknowledging the traditional custodians of the land on which we gather today and to pay my respects to their elders past and present. Where we are today, that is the Gadigal people of the Eora Nation. But I'd like to extend and acknowledge the elders past and present across Australia, wherever you might be today, and extend that respect to all Aboriginal and Torres Strait Islander people on this call. So welcome. Thank you for taking the time. I know it's a very, very busy time, but we really wanted to consolidate this webinar series with a kickoff webinar, with this is it. This is D-Day. 1st of October is on the weekend, and great way to start with a long weekend. We're about to find out what AN-ACC is all about in real life. So what we wanted to do today in the webinar, usually we've got some clients, some providers on board, but what we wanted to do today is just give you a run through of a whole bunch of things that we know about what's going to happen, and really just a snapshot of where you all should be at about now and what you should be thinking about now. So if you get through this webinar and you feel like you know everything that we've talked about, that's good. If you learn a few things along the way, then that's good too. But really, we're just trying to take this opportunity before we kick off on the 1st of October for the new world of AN-ACC, and try to give you as much real information as we possibly can to get you ready for the weekend. This is going to be a much more interactive session, so please, if you have any questions at all, put them in the chat. Really, questions fall into two categories for us. One is all the questions that we've probably heard a lot before, and we'll try to cover as many of the answers to those questions as we can in this session. Please ask them, because if you're asking them, somebody else might be thinking the same thing. The second type of question is a question we haven't heard before, and we're all learning. It's not like we've done ACFI to AN-ACC transition before, so we're all learning, and you might be asking a question we haven't thought of. So please ask your questions, and we'll be stopping regularly through the session this time to try to answer some of those questions from you. So let's get those questions in the chat straight away. I'd just like to also welcome Rob Cavino and Petra Awad on the call, and Rob's obviously one of our founders and my co-partner, and Petra is one of our consulting managers, and she's going to be monitoring the chat. So what we're going to do today, we're going to have a bit of a quick quiz. So the quick quiz is, there's no pressure there. I'm just going to run through a whole bunch of frequently asked questions that we get all the time. Just get from the get-go, let's just get those questions answered and get straight into it. Then we're going to go through our 7 AN-ACC focus areas. We've been really working on this. We're working with over 60 providers on transition programs right at the moment. And really, these are the 7 focus areas that we think everybody should be looking at as a priority. There's lots of other things to do, but that'll work out over the next couple of months. But these are the priority areas. And like I said, we'll try to take as many questions as we can throughout the session through the chat. So there's no way of taking those questions live. So please put them in the chat if you can. Thank you. So let's have a little bit of a quiz. What are the kinds of questions we get all the time that we can get out of the way straight away? So do we have to pay for reclassifications if they're unsuccessful, or if there's no change? The answer is no. The department's told us regularly that they're not planning on charging us. The caveat to that, though, is that there is a mechanism in the legislation to allow them to charge. So it's really about whether we develop any kind of nuisance value habits. If we decide we just want to reclassify everyone every month, sooner or later, they're going to start charging us for that. But at this point in time, they've said to us repeatedly, no, there's no intention to charge anybody for any of the reclassifications, as long as there's fair use. Number 2, can we include allied health, lifestyle, catering, etc. in care minutes? No. The answer is no. Of course, they've tightened this definition up back to the Royal Commission definition in recent weeks. And so it's really RN, EN, AIN or care worker time. But really we're looking, the caveat to that is we're looking for personal care time. So feeding, support, cleaning, dressing, washing, all of those personal care, direct care items. Are there other roles in your facility? Are there multiple roles, cross-functional roles in your facility that are doing direct care just like that? They may not be called care workers. That's where you need to look for those extra minutes, because you might have care work being done by a number of different people. So it's not maintenance, it's not catering, it's not lifestyle well-being. That's arguably being paid for under AN-ACC already. It's direct care minutes, and but look for those roles where care minutes might be trapped, even if they're the role's got a different name. What is the expectation of how quickly an external assessor will be at our site? 28 days. Now that's the service level. There's over 300 assessors nationally. 200,000 assessments is the quota they think that they can meet per year, and they believe that's plenty of capacity to allow for basically reclassification anytime, but you should see an assessor on site within 28 days. Of course, regional places, remote places, there might be some variation to that, but nominally it's 28 days. Can we reclassify at any time? Yes. The asterisk there is the caveat to that is there are some guidelines around it, but certainly the question of hospitalization or big mobility changes or 6 months, 12 months, that's gone. And so you should be able to use the reclassification processes and the free-form text to ask for a reclassification anytime you feel like their clinical requirements, their care needs have changed. And that is up and down. So just to be clear on that. Will the ACAT process still work in the same way, especially for respite? Yes. ACAT's not changing at this stage. It's working in the same way. You can't have anybody assessed before they come into your facility. So assessment for AN-ACC happens once they're in the facility. Respite, of course, anyone who's assessed for a low or a high respite will move on to the 101 and 102. Anyone who's 103, you're going to have to get them reassessed through a DEMI to get them into the higher level of mobility to be a 103. But everyone who has an existing respite at low and high should move automatically into a 101 and a 102. And that's going to be how their respite's done. But everybody else is going to be assessed for AN-ACC once they're in your facility, unless they're palliative on entry, which is classification 1. And there's a process for that, as many of you would know now. Will a resident be assessed for AN-ACC before they come into the facility? I just answered that. No, they need to be assessed once they're in your facility. Do I have to change my care plans to include AN-ACC assessments? We'll talk about that a little bit later on, but no, there's very much an intention to disconnect the assessment, the AN-ACC assessments, the external assessments relating to funding and your care planning. So really, it's a really great opportunity for the industry to really focus on care and care planning separately to AN-ACC funding and the AN-ACC assessments. Obviously, there's a need to connect those two and the information of those two, but no need to directly change your care plans at this point in time. And can EN minutes be included as RN minutes? Very common question. No, not at this stage. So the conversations we've had with the department, they're considering lots and lots of different options and models and changes. The key issues are, it was a very, very specific recommendation of the Royal Commission that RN minutes be RN minutes and RN minutes only. It's a very specific qualification. It's different to enrolled nurses in its scope and in its registration. So at this stage, at least, although they are still looking at it, EN minutes are not RN minutes. They are also considering various types of concessions in regional locations. But at this stage, EN minutes are not RN minutes. EN minutes can be included as in the care work minutes. Will there be any consequence to not meeting care minutes in the first 12 months? Well, arguably the answer to that is no, but of course there is the star rating. So the star rating is going to incorporate care minutes at a weighting of approximately 25%, we think. At this stage, we're still waiting for details on that algorithm, star rating to be published in December. So in the first 12 months until October next year, care minutes is not mandatory. So it's a good opportunity for the whole industry to learn and to transition, including the department. So not mandatory in that sense. Obviously, the quarterly reporting that you're just about to do for the first time is going to quote care minutes. That care minutes is going to be available to the department. It's going to be available to the quality agency probably. Also, in the recent webinar, the department confirmed that when they publish the star rating at the end of this year, they'll also be publishing, the intention is to publish your care minute target and your care minutes. So in the sense that they're not mandatory, they are potentially going to be published. So there's a little bit of a soft stick there, if you want to call it that. So will the government release the algorithm or assessment data in future? We've asked this question repeatedly. No, they have no intention of releasing any information about the algorithm or their assessment data or process in future. They consider that to be an independent part of the process, and they'd like to keep it that way. So we're not expecting to get any more information other than what we can gather from going back to the original RUC study and that sort of thing. So there's some questions answered, hopefully, right from the get-go, and many of you will know the answers to that pretty well. The next slide, I just wanted to bring this into our thinking. Certainly, it struck me when we were putting this together. There is the AN-ACC team, and by AN-ACC team at the top there, I'm talking about the department. I'm talking about Nick and Mark and his team. But in regular conversations with Nick and Mark, and the team, we are often reminded that there are a lot of other teams working on this transition and the broader reform. So the workforce team is a webinar just a few weeks ago, talking about a number of initiatives about how to improve the quality and quantity of the workforce that's available to aged care. So there's a team in the government, in the department, working very hard on that. Service Australia, as we all know, is a different section, and they're working very hard on the technology, and that's a very complex thing. The Quality and Safety Commission is separate. Treasury, who ultimately set the price and provide the funding, again, are separate. The AMOs, who are the assessors, and the consumer experience interviewers. They're contractors, they're set up that way to be independent deliberately. They're another group of people that we're interacting with, and the star ratings are being done by a separate group as well. So just a reminder, there's a lot of moving parts. There's a lot of people working together to bring this to us. And, I think we can reasonably expect a lot of learning and a bit of clunkiness for, not just the next month, but probably the next 12 months as we all learn how this plays out in real life. So we just want to get on to the big seven now. So the first of the big seven, in our opinion, is becoming your own assessor. And what we mean by this is the idea of an external assessment process is great, but certainly all the 60 providers we're working with and everyone we've spoken to, over 35,000 beds worth of industry, pretty quickly reach the conclusion that if you don't have a good handle on how to do these assessments yourself, it's going to be a little bit of a liability in your process and in your business. You need to understand how someone coming into your business at admissions, what their classification might be. You need to be able to see that in advance. You need to know whether when they get assessed in the first place, whether you're happy with that assessment. In some ways, we've become the validator. We're validating the assessor. You need to be able to understand the assessment process well enough to be able to do that. And certainly you want to know with some degree of accuracy whether a reclassification is available or possible for you, and be pretty confident in that outcome. It's really important for the practical aspects of AN-ACC that you can forecast. So you've got a very, very good handle on where your classification and case mix are going for your facility, and what the care minute implications of that are, so you can pass that on to rostering. And really understanding how admissions is affecting that, how reclassifications is affecting that, and how that's affecting your rosters is a very, very important aspect of getting on top of AN-ACC and how it's affecting your business. It's going to happen anyway, whether you like it or not. So on the 1st of October, AN-ACC kicks in. And for many of you, might be a really big boost to your funding, which is great. But if you're going to be in control of it and know how to manage it from then on, becoming your own assessor is going to be really, really important. Why is that easy? We do have a lot of information from RUCS and other places about how these assessments do work. Please come to us if you've got questions about that or you're confused about that, we can help you. But basically, I think you've got a better chance of being a good assessor internally because you've got great clinical experience in aged care in your business, because you know your residents really, really well. It's very hard for an external assessor to come in and look at a resident for a very short period of time and really see the longer term needs of that resident in that short window. And because the assessments are relatively easy to understand and they're being applied to a mathematical algorithm in a quite a basic way. So for all those reasons, you've got every opportunity to become very, very good at this. And therefore developing that capability and skill in your business is going to be very, very important. So there's a good opportunity to pause. There's a bit of information we've thrown at you. We've only done number 1 and there's 6 more to go, but we want to get some questions and find out what you're thinking and make this interactive. So let's find out what we've got. What have we got in the chat there, Rob?
Thanks, Andrew. We're getting quite a bit of questions, a little bit in flavor of this transition period of ACC data and then when the AN-ACC data will take effect. And that also extends into some of the expiring ACC fees that providers may have on their books that are presenting in September or even after October 1st. So I guess I'll treat the first question around what do we do with ACC fees that may be expiring after September 30th at midnight when AN-ACC takes place. So effectively, after October 1st or at October 1st, AN-ACC will be the classification tool, which will replace any of the payment data on those ACC fee outcomes. But if you have expiring ACC fees that land after that date, then we don't have to do anything about those expiring ACC fees. So that would be residents who maybe have a 6-month post major change or a new hospital entry, all of those that land on the other side of October, then we don't have to do anything. But any resident who enters care, even up to midnight of September 30th, then we will still have to run the ACC fee process to receive the payment of 1 or 2 days or how many days from when their entry took place in September after the process. The other side of that, Andrew, too, is a lot of questions around the AMOs and when they're notified and how we request reclassifications. And certainly, with that, about what information do the AMOs have on our service or on that consumer that we've requested. So I'll put a little bit of this in the context, Andrew. For the AMOs, they are only presented with the information once we check in a resident or interact with the My Aged Care resident movements, because that's how they're assigned and they will accept the residents that are now needing a classification or a reclassification request. So certainly the timeliness of how we interact with Medicare is going to be very important, because if we wait to check somebody in a week or 2 weeks after they've actually entered our service, that means that the AMO's process won't pick that resident up for the 28-day period, which is the KPI or SLA, which the department has imposed on the AMO organizations. So these are the assessment management organizations. So it is important for us to ensure that when somebody is new to our service, we check them on into the service on that day, and that will extend the process for when the AMOs will have visibility of that consumer now in your service. So that is probably an important note, and we did have quite a bit of questions around that. I guess the only other one to extend on that, we've seen a couple of themes come through in the chat, is around the information they have. So the AMOs and those contracted assessors, they do not know what historically that resident looked like. They are effectively presented on their application tool with your resident's name, and then they may have some of the context in which the reclassification button that you've selected, as well as any free text field that you put in there. That is all they have. They don't know the historical performance. They don't know the historical classification. All they know is that they need to do a review and follow their methodology and their system on those consumers that are presenting in their app.
All right, cool. Thanks very much for that, Rob. We'll keep coming back to those questions. So please, I know they're coming in thick and fast in the Q&A. Please keep bringing them in, and we'll try to answer as many of them as possible with themes like that. Thanks, Rob. Let's move on to number 2 now. Number 2 is about managing your care minute policy. And when we refer to a care minute policy, we really think it's an advantage for each organisation to actually write down in a very formal way, whether you call it a policy or guidelines or anything else, in a fairly formal way, how you are approaching care minutes, because there is guidance out there. There's a fact sheet. They just released the new guidebook, which is a consolidation of all the fact sheets. The fact sheets haven't been updated that much. The examples are still the same. They definitely are narrowing their focus on RNs, ENs, and care workers, as I was saying earlier. But there's still plenty of opportunity to look at multifunction roles, the roles of your facility managers, care managers, and other RNs, which are very precious minutes, and really looking at all of the different roles you have that may vary across facilities, regional size. There's lots of reasons why roles vary, even if they've got the same name. So really creating a policy and saying, here is all our different types of roles that we think have direct care across our facilities, and how you're going to measure them and percentages and all that sort of thing, and how you've interpreted the rules. And that's a really important document for a few reasons. One is, you can pass it over to finance and they can do their QFR. You can pass it to HR, and HR can look at moving that, reviewing that through the awards and the EBAs and the role descriptions, and try to make sure that it's consistent for the organization. That's good business practice. But also because we're getting new information all the time. And if we get new information and it's published, we can always go back to this policy and say, does this contradict anything? And if anyone knocks on the door, whether it's a quality and safety agency or anybody else, knocks on the door and comes in and says, how are you working your care minutes? You've got a document. You can go back to say, well, this is the document that we maintain that explains this. You have a look at that and you tell me if we're wrong. So I think that's a really important document for the business to create. Certainly QFR reporting is going on. The other thing I wanted to point out was this little picture here on the slide. It was in the webinar, the recent department webinar a couple of weeks ago. And I think it's a really important slide because I think it states their case about what's happening with allied health and lifestyle services. So very, very clearly, the AN-ACC funding does cover allied health and lifestyle. It also covers consumables and other things. It's just care minutes is one component of that, and care minutes does not include lifestyle, well-being, and allied health at this point in time. Who knows what happens when we go to 215 minutes in 2024? Maybe they'll incorporate a component then. But at this stage, direct care minutes, the policy is designed to increase direct care minutes. They believe the average is 177 minutes. They want to see that increase to 200. That is the policy. That is what they're trying to achieve, and that's certainly what they'll be wanting to see happen over the next 12 months. Obviously, we need this information to meet the star rating and populate the QFR. So if you haven't created a care minute and written it down, there's a lot of spreadsheets going around, but if you haven't taken the time to write it down fairly explicitly, I strongly encourage you to do that. Number 3, transitioning ACFI roles, the new analyst role. It's obviously most people are transitioning their ACFI roles to AN-ACC. For certainly in the first instance, you'll probably need the same capacity to look after your funding. The connection between funding and care minutes has now created complexity and certainly the learning curve for people in your organization. Probably more people in your organization are going to need to understand AN-ACC than they ever needed to understand ACFI. So the knowledge champion role of the ACFI coordinator and the ACFI manager will continue to be very, very important. So will identifying reclassifications and that sort of thing. So however you're going to manage that, that'll be very important. And most people are hanging on to that capacity and those resources. I think that the AN-ACC definitely lends itself to more centralisation. So those of you who are moving towards centralisation of rostering, centralisation of funding, it doesn't seem to require as much on-site work like ACFI did. You really needed to be very close to your residents and charting your residents and writing up information, assessment information based on your knowledge of the resident. That's changed with AN-ACC. So it does lend itself to more centralisation. And I guess more centralisation means more potential for outsourcing and capacity support. And we have a lot of clients talking to us now about how we can help them provide that support. But otherwise, ACFI resources will definitely be transitioning to AN-ACC for the most part. The other key resource that's changing is this analytical role. And some of you will have it sitting with your funding. Some of it will have it sitting with operations leadership. Some of you will have it sitting with finance, really depending on what your capability and the size of your business. But if you have a look at this picture on your right, if you have an AN-ACC classification coming in with your new resident, changing your case mix because it changes the average classifications of that cohort when they come in, you then have that flowing through to changing your care minute requirements and changing your rosters. If you want to manipulate those care minute requirements and keep your rosters steady or build your care minutes up to a higher roster that you want to keep or bring it down to a lower roster that you want to keep, if you want to be able to manipulate that, you're going to need to be able to identify reclassifications, hold them, sit on them, and then act on them when you think it's the right time to put somebody up or down based on those movements. That's an analytical process that doesn't exist with ACFI today. So who's doing that across those three functions? Admissions is still doing admissions, funding is still doing funding, and rostering is still doing rostering. But this information flow across those three things, trying to identify the impacts, the scenarios of what happens when that information changes. If you want to be in control of that, there will be a more analytical lens that you might need to put across that to make sure that that is stable and working. Obviously, minor tweaks to quality roles, clinical roles to take on some AN-ACC knowledge and understanding, and obviously impacts on finance and the QFR reporting and that sort of thing. So lots of other roles changing a little bit. Back to questions, more questions. What have we got, Rob?
Yeah, quite a bit about the care minute activities, Andrew, which may also open up to Petra to give some commentary on. I think you addressed some of them, but there are more specific questions coming around what time is counted as direct care and what is that extended to, such as can we include the time we are forecasting AN-ACC assessments or doing some of the clinical work of AN-ACC assessments on a consumer? Is that counted? And then a little bit of an extension about some of the wider activities that maybe carers, enrolled nurses, and RNs also provide, such as documentation time included on a resident's care plan or document maybe progress notes, I'm interpreting this as. So I guess start with those two before we get into some of the other wider questions there. But did you want to give a little response to those ones, Andrew or Petra?
Yeah, I'll start. So yes, anything that's related to direct care is included as we understand it. So, you know, if I think one of the reasons that we're advocating, we'll talk a bit later on about your rostering platform being your source of truth. It's very difficult to start building from the bottom up, capturing those minutes and trying to get to all the minutes. What we're looking for is all the rostered, worked, paid care time. And so every single minute that someone is paid to deliver care is included. And we think starting top down from the rosters is the best way to do that. So obviously the care time directly with the client, but also all of the planning, all of the care plans and the notes and all of that related to care planning is included. For your care managers, even the time spent with residents, with their families, organizing appointments and meetings with the residents and their families, doctors, all of those sorts of things, all of that time that relates to care time on admissions, trying to understand what their care needs would be, all of that time is included, as long as it relates directly to the care requirements, planning or discussing the care requirements of that resident. So that there's a starting point. Did you have anything else to add, Petra?
Yeah, I had a similar question yesterday from a provider. They were considering activities like that as admin. So it's probably best clarify the admin in the care minutes perspective refers more to your facility and staff or workforce admin. So your rostering, your budgeting, your finance, payroll, or your reporting that you do to the department. So the compliance side, not when it's related to administering the care of residents.
Yeah, admin of the business, not admin of the care. Yeah. What else, Rob?
And then just a little bit more of wider roles. The story about the physios, the OT, that therapy time. If it falls into direct care, but it's a different personnel, are they to be counted? And I think that's one that has been routinely visited. But maybe just give a commentary on the wider physio and OT's role in direct care, and then the eligibility to claim that in direct care time.
Yeah, allied health is out. So when I say out, it's out of care minutes. It's obviously being reported as part of the QFR, and it's obviously being tracked very closely because of that. I think to some degree, the department wants to watch it change, and they know it's going to go down because of the extensive use of 4B, and that's probably going to reduce. But they don't want to see it disappear, and they want to see it level out and balance. And I think one of the reasons they want to do that is to see if there is a consistent average that we end up with over a period of time under normal circumstances, which they could incorporate in care minutes in future with some confidence that that's a reasonable amount of time to be spent. It is an interesting question about, if a physio walks somebody down the hall, it's not counted. And if a care worker walks somebody down the hall, it is. That is the world we live in to some extent. I think if it's delivered by allied health, it's out. But if it's similar activities, whether it's by any member of your staff and it's an exercise-based, physical therapy-based exercise, that's still all care minutes. It's still all care minutes. It's just if it's being delivered by a physio or allied health, it's counted in a different place at the moment. And that's just the world we're in for now.
I think just to extend on that, there's a couple of chats on this feature role of the RN, and if the RN is on call but not working, can we count that? Where, I guess, that gray area of then this new approach to the 24-hour RN, do they have to be on site? I think that's where Tara is coming from about then if someone is on call, does that count? So a little bit more of an extended approach to then that care minute tracking.
Yeah, what we know is that the department is definitely looking at those, and especially for remote areas, co-located sites. They might be on different rack IDs, but they might be sharing an RN. 24/7 RN comes in July next year. So that'll be mandatory from July next year. They are definitely looking at on-call and shared and various other permutations, particularly for regional remote areas. They haven't come out with anything definitive on that yet, but we do know that they are considering those specifically. Yeah. All right, well, maybe we keep moving on. Good questions. Hopefully more questions coming in through the chat. So number 4, let's go to number 4. Number 4 is about transitioning 4B. We've talked about this. This is really about reviewing your pain management. Everyone in the entire industry should be doing this. There's no question about whether physio is still required or pain management is still critical in our sector. So really, it's a review of pain management. Most of the people we speak to, and we deliver a lot of training and workshops and services in this area, and everybody we speak to are very, very excited about the opportunity to take a better look at pain management, not be so prescriptive, to bring in every sort of therapy that they can, put everything on the table and be able to use everything. So lots of innovation happening in the space, a return to some of the old practices as well. Allied health might not be used as much as we have before, but certainly a lot of people are looking at how they can apply allied health more broadly into their care, not just so narrowly into 4B. So we've got this 5-step process. It's very important to find ways on an ongoing basis to be able to identify people who may or may not be needing pain management or escalation or review of pain management. A lot of you do that already. Pain check's a good example of where there's some ongoing monitoring measurement of that. The case conferencing itself to take a very systematic view and a very clinical view of how pain management's being applied. Tracking, this is a very, it takes a lot of time to get people into 4B, takes a lot of time to get people out of 4B. It's a very much slower process than most people realize. So if you're going to get on with this kind of review, get cracking, because it takes a lot longer than you think, and tracking how people are moving through the exercise of transition is a very, very important part to make sure that it moves as quickly as it can. You don't want to move too quickly, but you don't want to move slowly either. Innovation is such an important thing. There's lots of new things that people are trying. We find out which one works for the residents, which one works for the staff, and which one works for the business. They're really the three things we're trying to achieve here. And compliance, please circle back and make sure that documentation's in place, that you can explain why changes have been made, and that you can double check that, that there's no unforeseen consequences. So that's our 5-step process. It's a very exciting time for the industry because of this, I think. AN-ACC and the clinical system or clinical strategy, as we said earlier on in the presentation, the AN-ACC is an external assessment process. It is done by external assessors. The assessments that they've chosen are easy to learn, easy to apply. They really drive a mathematical algorithm, a yes-no decision tree. They're not designed to necessarily be applied to care planning and to be assessments that are useful for care planning. The government's been pretty clear that that they expect you to do the best you can with planning, the same way that you've been doing it now. You're now free of the distortion that comes from funding. So do your care planning and assess your residents' care needs the way that you think you should. Now, there are a few little licensing questions that are still floating around about the licensing of the existing ACFI tools and the licensing of the new AN-ACC ones. They're still being resolved for certain, but certainly your clinical assessments and care planning need not change because of AN-ACC. Having said that, you do have an external assessment process where assessors are coming in, not knowing the resident that well, applying these assessments, looking at your clinical information, and really using the clinical information that's in your system, not assessments, not AN-ACC assessments, just the clinical information, the progress notes, the assessments, the diagnoses, and the plans, really using that to fill any gaps, certainly around behaviours. We're noticing things that happen over a long period of time, things that happen at midnight, not at 9 AM, where they're looking at the resident. All of that sort of information needs to get into your system now and be tracked to support and really highlight those gaps. So that is important. How you are capturing ongoing observational information and progress notes and information into your care plans is very important, but still relating to care planning. If you the old anecdote, if you're doing care planning really, really well, that should be enough for AN-ACC, and to some extent that's true. But having some people in your organization who understand the assessments, the AN-ACC assessments, and what they're looking for, and how to make sure we're pulling the right information out of the system to support the classification result you want, that's also true. So you need a little bit of a blend of both. And that is priority number 5. So let's go back. More questions. What else has come through?
Yeah, quite a bit. I guess start with maybe priority 4 first, Andrew, which is the transitioning to 4B process. So some questions, I guess, more on the clinical quality side, which is how they would cease a program. Should they continue to provide daily or weekly after stopping the 4B? So I guess in the context of what AN-ACC is, it is a funding model that is just trying to prescribe the input costs and give us a portion of what the classification payment would be best to then cover those activities, those costs. So in the relevance to 4B, we don't have effectively a funding model now that prescribes funding based off of a specific pain management allocation. It is still up to the provider to determine what is the most appropriate form of pain management for that consumer, regardless of what the funding model is. And that's really where the scope of practice is now up to you to determine, not to the funding model in which, what we saw with ACC. It really, I guess it really prescribed 3 treatments of 3, 4A and 4B that the industry then got so aligned with in the practice of that. So really in that transitioning, what is now happening is that there is no prescribed outcome for specific pain management, but you do need to follow your accreditation practices, follow your, the standards, and also, look at pain management through a much wider lens, such as mobility, other medications, pressure area care, all other factors that there's evidence to support great pain management practices, but this mechanism does not prescribe how we have to treat pain in order to be funded on it. So that was a couple questions coming through on that, Andrew. I think the other one too, just to add on to that, around maybe the clinical assessment frameworks, which I may stretch it a little bit wider to include a lot of this palliative care for entry, and where that assessment information comes from. Is that the GP at the facility to fill that out, or what does that look like? So maybe Petra, I saw you reply to a couple. The palliative care entry process, is that something that the providers have to deal with, or is that something that's external? What does that look like? Because there's quite a bit of questions coming through, and I know there's a couple fact sheets that we've already sent out on this already.
Where do you attach? Yeah. Where do you attach the document?
Yeah, I've included a link in the chat. So the process is, there was a bit of questioning about when that needs to happen. So AN-ACC class 1, you would go through your regular entry in the system, and then there's an option to admit somebody as a class 1 or as all other residents. If you were to admit them as a class 1, then you have 14 days from the date of permanent entry to submit the palliative care status form. That needs to be filled out by a medical practitioner or an RN who is separate to the facility. So that could be from the discharging hospital, or it could be from the doctor who visits your facility, as long as they're not employed by you. Yeah, and that's pretty much it. Yeah.
Yeah, and that second part, Petra, is probably one that we had a couple more questions coming along about those GPs. So certainly if the GP visits your facility, they are in a direct relationship with that resident, that consumer, not with your organization. So that's what they mean by being independent of the organization. But if you employ that GP directly as under the provider, then there is a conflict of interest, which they are trying to keep independent from the care planning process. And certainly with the care plans, this independent party now has to provide, they do have an obligation to provide their APRA registration, their address of their practice. So there is more accountability to that palliative care side of it.
Yeah, I just need to clarify, it is nurse practitioner, not RN.
Yes, and then
nurse practitioner and medical practitioner.
And then I think the other part that's come from that, that's the clinical sort of context. I may stretch it a little bit around the second part, Andrew, which is really looking at these clinical assessments we use internally versus the really the mechanism of AN-ACC and how it was intended. So certainly the AMOs are under instructions not to use or refer to your assessments if it is a DEMI or the Rockwood, because they have an application to put those inputs in. So they will most likely just say thank you for that, but they will base it more on the observations and other items included. So if we do a DEMI and we give them a DEMI, they would still be expected to undertake it within their modified DEMI, because their instrument isn't using the full DEMI or some of these AFM assessment tools in the way they were originally intended. The department has changed them and modified them in a way that they are seeking to construct this funding mechanism within their algorithms tool. So that was just another area that has been noted in here. Any other ones there, Petra, you wanted to touch on? I think that was the main themes for the transitioning, and then some of the wider context around the clinical governance frameworks and providers really linking that into the AN-ACC tool versus care planning tools.
Yeah, there was just a question from someone on how the care minutes are targeted and whether rostering staff at different times of the day will have an effect on the care minutes. So yeah, just to clarify, the care minutes are calculated as an average across 3 months. So those smaller kind of deviations throughout the day shouldn't matter too much as long as you're meeting the average over the quarter.
It's also a 24-hour. It's a 24-hour number, so obviously they acknowledge that there's more going on and there's more minutes being delivered during the day than there is at night. So it is a 24-hour target. Yeah. All right, that's great, guys. Let's keep going and finish off these last few slides and then get some more questions at the end. Number 6 is care minute reporting. So we've got 2 more to go. Care minute reporting. Care minutes is a big deal now. For all those of you in the middle of QFR reporting, you know that care minute reporting is a big deal. You know, we've done analysis on this from time to time. We even did it in the annual reporting last year and this year. So it's not like we've never done it before, and all of you will have been, you know, reviewing your per bed per day minutes and that sort of thing for a long time. This is not new. But actually reporting it in a specific format and pulling out care minutes and tracking care minutes and having a specific definition of what is care minutes, who are those roles, how you capture them, that is something, and certainly doing it quarterly is going to be something that's going to be quite a burden on some organizations. You're basically going to finish one lot of reporting and you're going to be starting on the next. If you don't have a system or a platform that can do that for you, it is going to be more difficult. Our argument is, because your care minutes are really targeted at, you know, the minutes that you are rostering, the care minutes that you are rostering, the care minutes that you are paying for, really the best place to get it from is your rostering platform. If you can get your rostering platform to a point where it is capturing every care minute rostered person, certainly modern rostering platforms. There are a lot of people in the industry who have ended up with time and attendance modules hanging off their finance system. I think that most of those people are going to be looking at a full-blown rostering platform in time. That's really going to be very valuable, not just because it traps care minutes more easily, but because you've got fixed income and you've got fixed costs. So you've got care minute requirements and you've got externally assessed classifications. So you've got a fixed margin to a certain extent. One of the only things you've got to play with is the efficiency of really executing on that planned roster. And so having a system that's quite sophisticated to help you manage the execution of your rosters is going to be really, really important, particularly from a cost point of view. But in terms of care minute reporting, definitely if you can get the majority of your, or if not all, and again, good rostering platforms will include agency, your agency people in them. If you've got all of your agency people and all of your rostering people, all your staff rostered, your care minute staff rostered, even if they're staff, even if they're not clock on, clock off, you should be able to put them into your rostering platform and have them excluded from your pay run in that respect, and the time and attendance. If you can get all of that into your rostering platform, so that if anybody wants to know anything about your care minutes at any point in time, you can run a report directly out of that system that will tell you what your care minute target is and what your care minutes delivered were at any period of time, that when we get into the mandatory phase of care minute reporting 12 months from now, that'll be a breath of fresh air. That will be a warm blanket. If you can pull 90% of your care minutes out of one system, that'll be incredibly useful. So certainly food for thought, and something how you're capturing your care minutes and how you're getting your systems to help you do that, to make it to make it easier, and an extension of that, how well you manage those care minutes, and how well you execute those rosters, how well you can manipulate your rosters and your planned rosters to be more efficient or to change in line with care minutes, will be really, really valuable in time. Definitely worth starting to think about now. And the 7th one, lucky 7, is really in some ways saving the best till last or the biggest till last. AN-ACC, without question, introduces a new systems gap. It introduces a new area of transaction management that we just didn't have to worry about with ACFI. Admissions did its thing, funding did its thing, and rosters did their thing, fairly independent of each other, and most often reporting to completely different people in the organization, right up to the executive. So this is not something that we had to deal with in ACFI, but under AN-ACC, you will need to not only understand the impact of admissions and the changing classifications on potential care minutes, but the impact of changing classifications on making that problem worse or better before you pass that on to your rostering people and tell them whether you need more care minutes in your roster or less care minutes in your roster. This ability to play or ability to trap information is going to be very critical, because you're going to need to be able to identify reclassifications, hold those reclassifications without acting on them. It's not ACFI. You don't get an uplift and do it. It has consequences to your care minutes. So it's hard to just put that transaction through without thinking any more about it. You need to understand what those transactions are. You need to hold them, and then you need to see all the other information, and you need to be able to build scenarios to say, if I did this one and if I did this one, what would be the overall impact? Is that what I want? And then be able to communicate to that to your rostering people to either make a change or not have to make a change. This AN-ACC functionality that's required, this AN-ACC tool that's required, is going to be a very important step to all of you in your business. Otherwise, you're probably going to be doing it on a piece of paper or a spreadsheet, and that's going to be relatively difficult over time. So this functionality doesn't exist. We didn't need it. We argue it's too analytical for your clinical system, bearing in mind that your clinical system is probably the only one that the external assessors are going to have access to. So where do you want to be capturing your own assessment data? Where do you want to be playing with information? Where do you want to be building scenarios around what if we did this and what if we did that? Probably not in the system that the assessors can see. So we're building a tool that's separate to that, and we just want to tell you a little bit more about that. If we take permission to talk a little bit more about this, Mirus Metrics, which was formerly very much a reporting system, is now being built out to be a transaction management system for AN-ACC. Like we said, that functionality doesn't exist. So we've built it into Mirus Metrics, and we think that this AN-ACC application is going to become one of your key applications for managing your funding and your biggest part of your income going forward. In combination with your workforce platform, and we have a workforce platform called Mirus Works, these two systems are now going to need to work together to understand your classification changes, your scenarios, and how that affects your care minutes and demand, and then be able to execute those care minute requirements and those demands efficiently, because that is the only control really that you have over your margin. If you get that wrong, your margin's going to disappear. If you get that right, you will be able to maximize your margin based on the other constraints that exist within AN-ACC. So having two systems, one managing your AN-ACC and one managing your workforce really efficiently from a cost point of view is the future. That is what you're going to need to manage AN-ACC in the new world. So that's the majority of the information we wanted to share with you. We've got some more questions to do now. We can wrap it up in the last 5 minutes. Please get your questions in. But we wanted to make sure that this is a snapshot of all the information that we've got that's known, that we know. Here is a whole lot of answers. If any of these questions haven't been answered, please reach out to us because we've got a huge amount of information that we've accumulated over the last year, working with a lot of providers in the industry, and we're happy to share that information with you. So a few last questions. Rob, we've got a couple of minutes.
Yeah, just some questions on the reporting. Care minutes seems to be a very hot topic still, and certainly with, I guess, where this is taking us. And with the care minute reporting, though, there was firstly just explanation about how the case mix is calculated at a facility level. So maybe if you, Andrew, just give a quick little brief on what that looks like and how that calculation is made and in relationship to the RVU.
Yeah, obviously AN-ACC has three components. It's got the fixed component, $1,144 and change, not fixed, but the one-off. And then it's got a second component, which was based on the base care tariff, which is based on your facility that you would all know about. And then it's got a weighting, it's got a percentage, it's got a national weighted activity unit that's attached to a specific classification, and that's really what's being assessed. And that's how you find out, multiply that by $216.80, and that percentage gives you your dollar figure. You all know that. For each of those classifications as well, there's an RVU, there's a relative value unit. If you multiply that same relative value unit, whatever you've been assessed at, say class 8 is 100%, if you multiply that RVU by the target industry average, which is 200 minutes, it will give you your 200 minutes. So class 8, for example, the RVU is 100%. The care minute target for that resident is 200 minutes. What you need to do then is add up all of the care minutes for all of your residents, and that will be your total care minute. And if you divide it by the number of residents, that is the average care minute for that facility at that time. Over a 3-month period, the quarter, the department will know your classifications every day. They will know how long that resident's been in your facility, whether they've been on leave or not on leave. They'll be able to do that calculation. And for that quarterly average, they'll set that as your target for the next quarter. So based on the classifications in one quarter, they will work out that classification average, and they will set that as your care minute target for the next quarter, which is what you have to meet. You still need to know what your care minute requirement is every day, because you need to be able to forecast the potential rostering of care minute changes. Even though you've got a target, your care minutes might be going up. So your care minute target at the end of the quarter is going to go up. So the roster that you set 6 weeks ago is going to need to be in place at the end of the quarter when your target goes up. So you're still going to need to be forecasting your care minute changes. Also, there's a question when it becomes mandatory, whether the Quality and Safety Agency are going to walk in and say, your care minute target may well be 205 minutes, but we know that your care minute requirement today is 215 minutes. So you should be rostering to 215 minutes, because under Standard 7, that's actually your care minute requirement. Now, we've got a lot to learn about how the Quality and Safety Commission are going to deal with that after it becomes mandatory after October next year, but you should definitely be preparing to be in control of forecasting and knowing your care minute information in almost real time, so that you are in control of that decision-making process.
And this probably leads nicely into the next point, Andrew, was about the regulator's role here, because in the fact sheet it is known that they will be granted increased powers to enforce. But what does that look like? And I think, from what we know and what's in the Royal Commission's final reports, and specifically in sections around lifting the bar and regulating for the quality and safety of the consumers that the Royal Commission really exposed to change this whole system, both the commissioners were very critical with the powers that the regulator had in enforcing both practice, but also the data that they had access to be more preemptive in their approaches as opposed to reactive. And certainly one of the key areas that they've been very specific about is the ability that the regulator should not only assess compliance with the specific quality standards, but should also assess whether providers are being active, imaginative, and flexible in ensuring the quality and safety of the care they provide. So certainly to your point about if your target that was set 3-4 months ago in that period of time, but your distribution of minutes has changed materially, is the target then enough to say, well, we're flexible, we are managing the safety and quality, even if we have a deficit of 20 minutes a day in an RN, as to what the care minute had said with the changing landscape. So that's what we don't know yet. But I think if we look at what the intentions of the whole Royal Commission was seeking to do, and specifically around the regulator section, I think it gives a little bit of a foresight to see what may be coming from the commissioner and their mission, because largely we've only heard from Nick Hartland in the department side as they're working hard to really just get this new model, this transformation embedded. And certainly we will then start to recalibrate and really work through this year of amnesty before then we have the regulator starting to then increase their focus on the other recommendations that it came through.
Yeah, exactly right. Well, we're going to have to wrap up there. Just a couple of final comments. We do have a calculator app for AN-ACC on the website. We do have tools available in metrics and works to help you manage AN-ACC. If you need them, please reach out, but please download this app and learn more about the model if you haven't already. We are scheduling the next webinar 40 days, 40 nights. So we think that's a nice period of time after the first month to figure out what's happened. So please join us then to find out a little bit more about what the first month's meant and what's happened. But for any of the rest of you who maybe don't have the information that we've presented today and want to know more about it, please reach out to us. We're all in this together. It's going to be a very, very interesting time starting from the weekend. I think we're going from theory into practice, so it's going to be a really steep learning curve for everybody. And we're here to help you if you need help. So not everything costs money, so just reach out to us in the first place and seek some help, and we will do what we can. So thank you so much for joining, and we look forward to talking to you next time. Thanks, Rob. Thanks, Petra.
Thank you all.